Yeah.
Yeah. Okay, so we'll continue with the next case. This is a case of a 32-year-old woman who's got 4 previous vaginal deliveries and who's now pregnant spontaneously with monochorionic monoamniotic twins. She's got gestational diabetes as well. And then at 27 weeks and 6 days, she's diagnosed with a spontaneous intrauterine demise of one of the twins. They don't really have a reason for that, but that's when they refer the patient to us. What would you do if you receive a case like this? Anyone?
Okay, so volunteers. Come on, this is an easy question. So, the last person and the last row is just in front of you. So you just hand the microphone to, yes.
No pressure.
What would you do? Call a friend? I mean, that's an option.
Yes, friend.
Yeah, there's no friends. I mean, it's a Saturday evening, so.
To ask
in the
when
pub.
was the first the fetal death happened? Like, did they tell details? Like, was there any high drops or edema in that IUFTs to define whether it was 24 hours above and after? Was there any gap of 24 hours or more? Then
We don't know.
Then we might have to do the MRI for the other baby and decide for the counseling based on that, like, because there's 20% chance that there can be a brain injury in that baby.
Okay, and if there is no brain damage in that baby, what would you do?
Okay, so pass the microphone to...
And when would you assess the brain damage?
Immediately or later?
Depends upon, I don't know, maybe immediately or 32 weeks.
Okay. Do you remember the algorithm when we said that we do like 4 to 6 weeks? You remember? Yes, yes. Okay.
Okay, so what we did, we actually only saw her around 30 weeks. At that time, it was normal brain imaging on ultrasound for the remaining twin. And we could see clearly cord entanglement, which is not abnormal in monoamniotic twins. So would you do anything at that time, or would you just wait, and what would your management be?
Okay, so my friend from Chile at the back row. Anything. What would you, I mean, what do you think?
Yeah.
Do nothing is an option, you know?
And this living baby is, of course, at risk, clearly. One from the IUFD side and 2 from the cord entanglement. That baby need to be closely monitored by Dopplers and CTGs.
And when would you deliver? Would you deliver like you would do for monoamniotic twins between 32 and 33? Would you continue further in pregnancy?
I would say not beyond 34, I wouldn't.
Okay.
Any other views? You are allowed to disagree, it's fine. Okay, why not wait until 36 weeks? What are you worried about? Double I. You worry about this baby also dying, yes? And that's why, so why 34 weeks? Why not 32 weeks?
Is this a prematurity thing? That is why.
Okay, so you chose 34 weeks because it's a good compromise between the baby being too early?
Yeah. As long as we are monitoring that baby and the baby is fine, then you can push pregnancy as much as possible, but not beyond 34. Because by then, prematurity is much less. And risk of IUD then become high.
Okay.
You'd have to have sort of a negotiated settlement with the patient as well, because I think at the end of the day you want to give her one healthy baby now, so the gestation that you deliver on is going to be a compromise situation between her wishes and yours to maximize the maturity of the baby.
Excellent. Great. Anybody have any different opinions? Yes, here we are. Good.
Do you need to do the MCA on this living fetus to see if there's any signs
Well,
of
at the
anemia?
time when you diagnose the IUFD, you would definitely do that to see if the fetus is anemic at that moment, yes or no. If it's anemic, then best option would be to maybe transfuse and wait, give it time in utero to see whether the brain develops normally, yes or no, and just not try and cut it out immediately. But here we are worried about the cord entanglements, because you can monitor all you want, it can just go wrong very, very quickly without any signs that something is going to happen. That's why we counseled this patient to have a cord transection. The advantage is that if the procedure goes well, the risk of cord entanglements is gone, and you can maybe prolong the pregnancy further than you would with monoamniotic twins. So what we did is we did an MRI first before the surgery, just to make sure that there was no abnormalities in the living baby at that time, which was normal. It was only 3 weeks after the event though. And then we planned for an intervention at 31 weeks. So what we wanted to do was go in with a fetoscope and then look at the dead cord and transect it by laser. But that didn't go quite as planned, because this was what we saw, which was nothing. The fluid was very dark because, of course, this other baby had been dead for a few weeks. So I thought, well, this is going to be over quickly. Okay, we can't do anything. But then we had some very inventive fetal surgeons who said, well, maybe we're going to try and grasp it with a bipolar clamp and see if it's fragile or not. It wasn't. So we started to coagulate until it thinned. And then with a lot of amnioinfusion, we could laser part of the cord so that it was almost transected. And then with a nice pull from Professor De Vlieger, it finally came loose from the abdominal insertion sites. And then our patient continued to be pregnant until 35 weeks, and she delivered a healthy boy. This is the placenta, where you can actually see that the clamp in the middle here is the cord of the healthy baby, and this is a dead cord. It's very long because we cut it off here somewhere at the site of the umbilical insertion. And you see that the surviving baby has actually recruited the entire placenta, which is quite abnormal. You would expect some part of the placenta to be dead, the part that belongs to the demised twin, but actually the entire placenta went to the living baby. Okay.
So I guess the message is that if you have a single IUD in monochorionic monoamniotic twin, and you're hoping to continue the pregnancy, that you should seriously consider the option of cord transection, which is technically might not be easy.
But I think this was the most difficult case that we have seen.
Challenging.
Well done.
So the next case is a 23-year-old primigravida with a spontaneous MCDA twin pregnancy who had a normal first trimester scan and normal NIPT, because in Belgium we usually do NIPT instead of the combined test now. But at 15 weeks there was something in particular. We had a single umbilical artery, which is not very important in one twin. Both had intermittent absent and diastolic flow in the umbilical artery, but like we said before, that's possible just because it's very early still and can still normalize. Growth was fine, fluid was fine. But then we had this in one baby. So you can see that the hands are not really moving much, and then the feet, the legs were straight like this, and the feet were flexed and they were not moving. So it's MCDA twins with arthrogryposis in one twin, or amyoplasia. There are some reports of this occurring in monochorionic twins, in one of a monochorionic twin pair, and it's thought to be a problem arising with impaired blood flow, where the anterior horns of the anterior horn cells are damaged in the spine, and this leads to this kind of image. What would you do if you see this at 15 weeks?
Okay, volunteers. You have the lights on. You're not falling asleep, are you? Okay. We have volunteer from St. George's. Come on, there's a big team from St. George's. Or from Norway. Norway, Hetty.
Okay, from Norway, volunteering. In Norway, we don't have the possibility to do fetoscopic procedures because we don't do them. We are too few people living in Norway, so we send them abroad. If she would opt for selective termination, we would probably send her to Copenhagen. So.
Okay, very good.
So we would
good
answer
answer
her for that possibility.
Yeah.
We can't do it ourselves.
Excellent, thank you.
Okay, so what we did, we saw her again at 17 weeks. Of course, the anomaly was still there. We saw that the affected twin was slightly smaller with normal Dopplers and that the cords were very close together, right at the intertwin septum. Because this kind of pathology has been described in cases of twin-twin transfusion syndrome where there is a transfusion imbalance. It could also be, because there was no TTTS in this case, the cords are very close together, which also predisposes this patient to blood shifts, which might be the reason behind the condition. And we talked about actually several options, either continue the pregnancy, conservative management, but we know that this condition is sometimes associated with cerebral lesions as well, so quality of life can be really quite poor. We talked about the possibility of terminating the entire pregnancy because that's the woman's right to do so if she does not want to continue with this. And then we talked about selective reduction. Either she would go for early selective reduction around 20 weeks, but then we still have the risk of miscarriage and the risk of prematurity, or we would go for late selective reduction after 28 weeks, which reduces the risk to the co-twin because you will not have the risk of procedure-related miscarriage, you will not have the risk of procedure-related preterm birth, but you still have the risk of sudden intertwin fluid imbalances that could lead to demise of one or both. So in the end, the patient opted to have late reduction. But when we saw her again at 20 weeks, there was a very small defect in the intertwin septum that we could see with one loop of the umbilical cord hanging in the other amniotic sac. And then at 25 weeks, it was clear that the feet of one baby were in the sac of the other baby. And the healthy twin had mild clubfoot on one side. So at 28 weeks, she came in for her intervention. We did an MRI first just to make sure that there was no abnormality in the non-affected twin, and it actually showed polymicrogyria in the affected twin. She got steroids before the intervention. She got a combined spinal epidural so we could do a backup cesarean, and then she had a bipolar coagulation of the cord and then transection because it was now a monoamniotic setting. This is a small video of the end of the transection where you can see that most of the cord has been transected already and there is still a very small piece that's left. The image is moving quite a lot because the patients are not sedated, and it was the end of the procedure. The patient got a little bit emotional and she was breathing quite heavily. But even though you can see here the final bit of cord that we are about to transect, and then it's nearly done. And now it's gone. Okay. So what happened when she was almost 32 weeks, she ruptured membranes. She was not in labor, but she was bleeding quite a lot, and that's why they performed a cesarean section at that time. She delivered a healthy girl of 1.7 kgs, which was doing well, and then the demised co-twin followed afterwards. And this was the placenta with the detail of the umbilical cords. The lower cord here is the cord of the healthy baby, And this is the cord of the demise twin, where you can still see the indentations from the bipolar coagulation. So the cords were very, very close together with very big vessels running in between. Okay.
Nice. So, I mean, I guess you can clearly see that the management of discordant and anomaly in twins is not straightforward. It's quite complicated.
Okay, so the next case is a 34-year-old who's got 3 previous term deliveries with a history of diabetes in pregnancy. She's a smoker. She had visits with her own gynecologist at 8 and at 15 weeks. She also had an appointment for a 12-week scan, but she cancelled that herself. And then she was seen again by her doctor at 20 weeks, and there was a suspicion of anencephaly in one of an MCDA twin pair, which is quite a shame, of course, because this maybe could have been diagnosed sooner, but, well. We saw her at 21 weeks with one normal-looking twin with normal amniotic fluid and one abnormal twin with anencephaly. You can see here the eye sockets and nothing above it. But also there was no bladder. There were no normal kidneys, and the DVP here was 2.5 centimeters. But yeah, that was relative large measurements. The baby was actually more or less stuck. So what would you do with this?
Nothing.
Well, there is not a lot that you can do in any case, because this fetus was completely stuck to the posterior side. There's no way to access. So what we did was we just said, well, you can have your follow-up with your own gynecologist, and then we'll see you again around 28 weeks to see how things are progressing. And then around 27 weeks, she came back to us with, at that time, deepest pool of 1.8 in the abnormal twin and 11 centimeters in the other twin, with a closed cervix, no bladder in the abnormal twin, but like I said, there was also no normal kidneys that were seen, so no bladder might be related to that. And we saw the cord insertion site, so here is one cord, here is the other cord, with a big anastomosis in between. So strictly speaking, this is a TTTS, stage 2, because there is no bladder. What would you do?
Okay, let's ask. Come on. So Shen, what do you think? What would you do? Yeah?
Ooh, I don't know.
Tricky, isn't it?
It is.
Just think in a loud voice. See what you think. I'm thinking.
You could potentially try and laser, but then you're probably above the upper limit of that now, aren't you, at 26 weeks?
Or 27 weeks,
Yeah.
yes. Would be challenging as well, because it's big.
The two umbilical cords are very close. But what about cord occlusion of the abnormal baby?
But there's no Lycor around it, is there?
Amnioinfusion? Or maybe go, because you can see the cord insertions there, so I guess if you do fetoscopy and you can get to that, potentially you can do cord occlusion. You have to go through the membrane, of course. Or maybe amnioinfusion of this baby.
But you couldn't access the sac directly.
Okay. Kurt, yes, please. Kurt.
Oh, okay. There you go.
Yes,
I would do a laser, why not? I mean, you can even see anastomosis.
exactly.
It's a
Try to do
posterior
laser.
placenta, do a laser.
Yeah, because even if this baby dies, at least you protected the surviving twin.
Can I say something? Yeah.
Yes, Elizabeth. Because it's a posterior placenta, so technically.
Yeah, I mean, but these are huge vessels, and I'm a little bit worried, Kurt, about because single demise is not uncommon after laser therapy, and what if the healthy baby dies and you're left with the anencephalic twin after your laser procedure? Because these are challenging. I mean, these are not classical TTTS. I wasn't even sure whether this is TTTS because there's no kidneys in the so-called donor. So these are atypical.
But this baby have polyhydramnios, the other ones. Why would the other one have polyhydramnios if it's normal?
Well, I mean, you can, yeah, I mean, there is diabetes for one thing, and I mean, you can't validate one of the criteria
Okay.
because-
But is it big bladder, for example, or
Yeah.
abnormal Doppler?
Yeah.
Any other features of TTS?
No, actually, Dopplers were fine. Bladder was not small, but not very large, as you would expect in TTS. Also, she had no complaints at all. Cervix was closed.
I guess what's the chance of this if the baby that's abnormal dying with no kidneys and acronia? I mean, I think it's high. No. There's the one that the abnormal with baby. There's a high chance the baby might die.
Well, can't you just sit tight then if we're not?
Well, you need to protect the other baby.
Just sit tight, don't
You
you?
need to protect the other one.
Yeah.
Okay. Any other views? Come on. You can see everybody. It's a quite challenging case, so you need to contribute to the
I
discussion.
mean, your options is if you can't intervene, you either sit tight, wait and do anything, or you deliver. So you steroids and deliver. Those are your only two options then, aren't they?
Which is only 27 weeks.
Yeah, I know. I'm just saying, but that's those are the only two options you've got. You sit tight, hopefully things.
But what about the
Whatever.
option of what Kurt suggested, which is to try to do laser?
I think Lewis, they weren't so keen, were they?
I still would do a laser. Why not? I mean, just go in with a fetoscope and look how what it looks like. Why should there be single demise of the one with the polyhydramnios? It could be, yes, but I mean,
I guess a chance.
what would be the
You could also
alternative?
die when you do nothing.
Just do nothing. Yes. Well, yeah.
Okay, so tell us what happened.
What we did is we did nothing. She had follow-up with her own gynecologist twice a week. Yeah, she was from quite far away and she had no car, so it was very difficult to come to Leuven. She was not very happy to come to us either. Everything remained stable.
What did you tell her?
The polyhydramnios remained stable. There were no contractions until 29 weeks and 3 days when she was admitted with contractions, with a cervix still of 22 millimeters. They were ready to transport her to us to either see if we could laser anyway or at least reduce the fluids in order to stop the contractions. But then they saw that both babies were actually bradycardic during the contractions, and they did an emergency cesarean section with demise of the anencephalic twin shortly after, confirmed no kidneys, no bladder, and 4 fingers on each hand. And then the other one was a healthy boy of 1.3 kgs. So yeah, we're not happy that she delivered this early, but we're happy that she has a live baby.
Okay. Any comments? Yeah. Sure.
I mean, could you consider, if you really was worried about laser and the connections, I mean, not that it's one of the kind of best modality of treatment, but amnion reduction at that time to try and...
Yeah, we discussed that, but she already had 4 term deliveries. She had a long cervix, no contractions. That's why we decided to wait until she would become symptomatic. Okay. And the plan was to do a reduction then or go in and see if it was possible to do later. But we didn't get to that.
So very challenging. I mean, you see, this sort of is not a straightforward case, and anybody would be, quite have to think about the options and the implication of each option. But that's great. Thank you very much. Any other questions, comments, anything from the live stream?
No.
Oh yeah, no. There is Lata from Bull. She said, do nothing with anencephaly may die. Yeah, well, it died. Oh, wait, 1 second. There's another comment from Rajiv. Twin with polymicrogyria, is there any genetic diagnosis? I mean, it's interesting because actually the baby had anencephaly. It wasn't just anencephaly. The baby had also other associated abnormalities.
Yeah.
But I don't know whether she had any genetic testing or not.
They sent a biopsy for genetic evaluation after delivery, but we couldn't do an amniocentesis safely
Because it was
during.
anhydramnios
No,
anyway.
because it was completely stuck to the posterior wall.
Yeah.
So we didn't.
Great. There is another few questions from the online streaming. So with the demise of one twin, with loss of pressure in the cord of the demised twin, is it possible that the living baby is at less risk? I think it's in the context of a monochorionic, monoamniotic twin, I guess.
I don't understand the question fully.
So I think he's asking whether if one baby dies,
Yes.
you will have loss of pressure in the cord of the demise
Yes, but it will
twin.
get very rigid. So it will
Yeah.
wind around the other cord and just tie it off. While when it's alive, it's
It's got-
softer flesh, you know, it doesn't really tie off.
yeah.
So
Okay.
we've got some cases where you can actually see this healthy cord being tied off by a completely fibrotic strand of cord from the demise twin, and that can happen like weeks later, unexpected. So
Yeah. So, and therefore, actually, the answer is not at less risk, it's actually at higher risk. Okay, there is another question from Elizabeth. Is there a place for cord release?
cord release.
I guess means transaction. I suspect
We
it
did
was
that.
relevant to the case that you were discussing earlier. Okay, great. Thank you very much. Next case.
Yeah. Okay, so the next one is a 37-year-old lady with one previous preterm birth spontaneously at 32 weeks. She had multiple surgeries for endometriosis. She herself had a double renal system on the left that was reimplanted as a child. And she's now carrying DCTA triplets after egg donation. And we see her at 11 weeks.
Does she have any uterine abnormality?
Not that we know, no.
Because preterm birth with renal abnormalities. Interesting.
Well, I hope that they screened her during the fertility treatment for that.
Okay.
But we couldn't see any, no.
Okay, so who's you had a lecture on triplet and you had a reduction on lecture on selective reduction. So who will volunteer to say how would they counsel this woman at 11 weeks? Need someone brave.
Oh.
Yes, go ahead. Spain.
We will advise to do a fetal reduction to one singleton.
Okay, so but you will tell her the options, is it?
Yeah, we will tell the options. Yeah,
Okay.
of course. Yeah.
So you're saying that it's a good idea. So if you're going to do reduction, which one? Which baby? Which triplet?
What we will advise is just to a singleton pregnancy. So just.
So reduce the monochorionic pair, so you continue the pregnancy with singleton. And she has a history of preterm birth as well. She had a 32 weeks baby before.
That's why.
Okay, so Isabel, tell us what happened.
Of course, we explained all of that to her, but like you said, IVF patients, so she chose to continue with 3 babies.
Like many of them do.
So at 12 weeks, everything looked fine. Growth was okay, normal fluid for all babies. And then at 16 weeks, we saw that there was one boy, the dichorionic triplets, and then MCDA twin girls with concordant growth and actually acceptable amniotic fluid for both. Maybe a slightly smaller bladder in one of the two, but nothing that was really very concerning. And then we continue to follow her regularly, and then at 22 weeks, finally, we arrive at a stage where for the MCDA twin pair, there is an 18% discordance in growth with deepest vertical pool of 2 centimeters in the smaller twin with slightly small bladder. And then the other one had a DVP of 7.5 centimeters and was clearly bigger. So what is going on?
Okay.
Not too hard.
It's not difficult, come on. She's asking whether Dopplers were normal.
Dopplers were normal, yes.
So what do you think what do you think the diagnosis is likely to be? TTTS, okay, perfect. TTTS, yeah.
Okay. But then we have this in the smaller baby.
Okay, what do you think is that? Multicystic kidneys. Okay.
Yeah, multicystic.
The mother had also kidney problems, isn't it? So.
But it was not her eggs. Sorry, she was pregnant after egg donation.
Oh yes, it's a donor egg. Can't blame the mother.
So we have a polycystic kidney on the left side, and then on the right side we had slightly smaller looking kidney.
And this is which baby? Which triplet?
This is a small baby with less amniotic.
The one of the monochorionic pairs.
Yes.
But the other baby had normal kidneys.
Yes.
Good. Okay.
Okay, so what we did, well, we just followed her well, at this stage she also saw the pediatric nephrologist who discussed all possibilities going from either kidney function will be okay at delivery or might be this bad that the baby will die, we'll see. She continued with all three anyway. She was not up for any selective reduction at this stage either. So we continued to follow her, and then at 27 weeks and 5 days we admitted her for fetal monitoring and steroids. The boy at that time was also growth restricted with brain sparing. The small girl had very little amniotic fluid but normal Dopplers and always a little bit of urine in the bladder. The bigger girl was doing fine actually. The mother had mildly elevated BP and slightly elevated proteinuria. At 29 weeks, we saw that there was intermittent absent and diastolic flow in the umbilical artery of the boy and the smaller girl, with both brain sparing and anhydramnios for the smaller girl. We were thinking about maybe delivering, but then it was only 29 weeks, so we tried to hold off. She had normal CTGs the whole time, and when we repeated the Dopplers the day after, they were actually back to normal or acceptable. But then at 30 weeks, the growth of the boy was slowing down, the growth of the girl as well, and then the Dopplers were deteriorating for both the boy and the smaller girl. So we decided to repeat steroids and deliver. She had a cesarean section at 30 weeks and 5 days. She got Maxel for neuroprotection, delivered a 1.3 kilogram girl, and then a boy and a girl of almost 1 kilogram, and the girl was confirmed to have a multicystic kidney on the left side, but actually a normal kidney on the right side, and we saw that the creatinine was high at birth. It continued to rise for 3 days, but then it actually got back to normal spontaneously, and then at 14 months they're all doing well with normal neurodevelopmental follow-up. So I guess we got lucky again.
Happy ending. Any questions or comments on this case? Would you have done something different? Happy? Great. Okay. Next one.
This is the last one. It's a short one. It's 28-year-old Gravida 4 para 3. 3 previous term deliveries, but with children of about 2.5 kilograms. She's a smoker. She already had an NIPT, which was normal. And then her initial scan showed 1 fetus, she told us. Then later they saw a second fetus as well, but it was a lot smaller, so they referred her for discordant growth. And then this was the ultrasound at 12 weeks and 6 days. So there is indeed discordance in size. But as you can see here, there is a very nice picture of our smaller twin who's got his legs stuck up here. And this is a clip where we can see that even though the NIPT is normal, the baby is not. The legs are completely fused from the pelvis to the feet. The feet are standing outwards like this. It also looked like there was an extra toe. There was no bladder, no kidneys, little amniotic fluid. So this is a very easy case of anomaly in dichorionic twins. So we talked with her about possibilities of continuing the pregnancy or either having a selective reduction early or late. But this is not really a great candidate for late reduction, as she already had 3 previous growth-restricted children, so maybe she's not the ideal mom for twins. So she opted for selective reduction at 13 weeks and 6 days with xylocaine injection. And she delivered a healthy son of 2.4 kgs after induction for growth restriction. So that's it.
Great. We had a very similar case recently. Yeah. Would you test for chromosome abnormalities at the time of the selective reduction or not?
At the time of selective reduction, we didn't.
Would you? I mean, would you like to or not really? Doesn't matter.
It's with this kind of condition specifically. I think the chances are not as very high that you are going to find something genetically. Depends on what the anomaly is, I think. If you expect to find something, yes or no, and here
not going to change the outcome anyway.
This mermaid syndrome, I don't think you.
Yeah, great. Okay, any questions, comments? Okay, so, oh yes, there is a question or comment at the back. So we need a microphone, and I'm looking at the online streaming.
Quick one. Yes, from the experience of that last triplet, and I'm sure many others whom the mom opted to continue pregnancy.
Yes.
And their outcome. Would these type of cases sort of let us revisit the issue of selective reduction for triplet?
But you also have cases where it doesn't end well.
Yeah, of
so
course.
that's just not the very nice cases that we like to present.
Sure, sure.
I mean, look, I think it's still if they continue with triplet, I mean, 90% survival, more than 90% survival. So, it's not continuous triplet pregnancy, despite the fact that the risk is still the majority of them will have a decent outcome.
Yeah.